This is a wonderful career. You work with smart people. It's challenging on the financial side, but it's a fascinating, challenging career because you're working with science and technology, and you're also working with the patients who need you to do that right.
Hello, everyone, and welcome to the Radiology Report podcast, where we are having conversations with the leaders transforming radiology today. You can find us on radiologyreportpodcast.com, Apple Podcasts, Spotify, Google, or wherever you get your podcasts. I'm your host, Daniel Arnold. Today, we are joined by Robert Still. Bob is the Executive Director of the Radiology Business Management Association, or RBMA. Bob has been involved in the organization since 1992, serving as past president, member of the board of directors, and Federal Affairs Committee. He has served as the practice manager of Lancaster Radiology Associates for over 2 decades, overseeing the diagnostic radiology services for multiple medical practices. Additionally, he has held notable positions as the chief clerk of Lancaster County, Pennsylvania, CEO of Brain Orthopedic Spine Specialists, and most different from anyone on the podcast, Delaware State Senator from 1986 to 1990. In early 2020, Bob launched his own podcast, which I'm a big fan of, called A Word with Bob. I'm personally really excited to have Bob on this show this week. The RBMA is a really interesting organization. We'll get into it. We've been a partner of theirs for some time, helping both radiologists and specifically business managers within the radiology world navigate the complexities of building, owning, and running a practice. And to his experience in this field, he's seen radiology from pretty much every angle there is. So super excited to have you on the show. Thanks, Bob, for joining us.
Thanks, Daniel. Looking forward to chatting and appreciate Modality's support of RBMA. I first found out about MRI online. I think I was in Mississippi. I met Kelly, and she was just exploring RBMA and possibility of marketing. So I appreciate you all stepping up. You've really grown, and it's really a cool product. Yeah, thank you.
Well, the partnership has been mutual, and we're big fans of yours. So tell us a little bit about your background. Where'd you grow up? How'd you find your winding path into radiology?
I have a varied background. I have to tell a story. I'm not bragging. I never thought of my resume as being interesting. It's just been kind of my pathway, my professional pathway. And Lancaster was a home of Armstrong World Industries, which has gone through bankruptcy in many different versions. But the former CEO there, Bill Adams, Bill and I got involved politically in Lancaster several years ago. Bill looked at my resume and he goes, "You have the most interesting resume I've ever read." I go, "What do you mean?" He goes, "You've done so many different things." And I'm like, "Oh, well, I consider that to be a compliment coming from a guy that was the CEO of a major kind of industrial home, industrial organization like that." So yeah, my pathway started in Indiana, Fort Wayne, Indiana, in a big family. Went to Catholic school there for 12 years and then went to Indiana University and got a degree in education and started teaching. Like most of my family were teachers. So kind of an interesting pathway into management.
Well, and I understand you were one of 7. Is that
one of
right?
7 kids? Yes. God bless my mom and dad. We're baby boomers, after the war. Although Dad was in the Army, got drafted late because he was a teacher. So he didn't really ever have to go into active war zone. The war ended, but part of that generation. Yeah. So I, number 5 of 7, my mom used to say to my wife that she assumed I was a good kid because she doesn't really remember me as a kid. So I must have been good.
You must have 7 kids to be able to make a comment like that.
But we weren't the biggest family in the extended Kelly family. I had an uncle had 11 kids, another uncle had 8 kids. So I lived in a kind of the quintessential post-war neighborhood where everybody walked to school, went home for lunch. It was what you remember on TV, all that stuff. That's the way it was. It was really a great neighborhood in Fort Wayne, Indiana. Yeah.
Well, and Lancaster is still a pretty small town from what I gather. So
it is, yeah.
You haven't gotten too far away from that, community feeling.
Lancaster's an interesting geographic location because it's like an hour north of Baltimore, an hour to Philly, a couple hours to New York City. So there's a lot around that area. You can get to a big city pretty quickly, which we do.
So tell us a little bit about the RBMA. How did it come about?
Sure.
And how did you find your way to the organization?
Sure. Well, the RBMA was founded in 1968, so 55 years ago.
Wow.
Yeah, I've been around a long time. And The impetus was when Congress passed the Medicare law, under the Social Security Act in 1965. Part of the, Johnson's Great Society was to, we need to cover seniors. At that time, I think it's like 20% of all seniors had health insurance, and that was it. So Medicare was founded along with Medicaid. And as part of that, the whole process of, well, we've found this guarantee health coverage for seniors, how will hospitals and doctors bill for it? So there was this great debate about Part A would be hospital billing and Part B, Medicare, would be physician billing. And the story goes that there was a physician, Dr. Joseph Calhoun in Arkansas, radiologist, very involved with kind of the emerging, where does radiology fit within Medicare? At that time, many radiology groups, hospitals billed for their services because they were, part of that. They call it the RAPS physicians, radiologists, anesthesiologists, pathologists, emergency room physicians, people that work primarily in and around hospitals. A lot of groups, the hospitals billed for those services. So, there was this great debate over where did those physicians kind of sit relative to Part A and Part B. Should they be in Part A because they work at hospitals, or Part B? Are they really independent physicians, that kind of thing? So Dr. Joseph Calhoun, who was one of the helped found RBMA, in fact, our biggest award to a member is the Calhoun Award. He was good friends with, at the time, the chairman of the House Ways and Means Committee from Arkansas, Congressman Wilbur Mills. And Wilbur Mills was a powerful member of Congress at the time in the 60s. And he convinced Wilbur Mills that radiology should be part of Part B Medicare and should bill under Part B under the physician fee schedule. And that influence, Dr. Calhoun's influence, that's what enabled, that's Mills basically put it into Part B, and all of a sudden radiologists could bill independently. And it shows you the influence of one person in Congress.
Well,
but
absolutely.
It really was
we've actually had a congresswoman on our show,
Right.
a more recent congresswoman, talking about how radiology, she led basically all the work to ensure mammography screening is covered by insurance as part of the Affordable Care Act. And then, the second stage of that, later in the decade. But it's been a common theme on the podcast is the importance of advocacy. And here you have maybe one of the earliest stories, earliest examples of physician advocacy, radiology advocacy in particular, having sort of a profound impact on the interests of the field. So what are the downstream effects of that decision? How does that impact the field?
What happened back in the late 60s, early 70s was all these, at the time called office managers for these radiology groups, primarily women. They were women that did transcription, executives, they did everything for the physician groups. They were tasked with trying to figure out how to bill Medicare, how to bill independently. And, one thing leads to another, and a group of them get together and develop the Radiology Business Management Association. It was founded in the state of Illinois. Their first meeting was in Chicago. The topics included, like, how do we bill? How should we set up physician retirement systems? Those kinds of conversations. And we still have those conversations. So it was professionals getting together and talking about and sharing information about coding, billing, collecting, managing revenue cycle. That was really the basis of RBMA. And it still is the basis of our existence. How do we correctly manage a physician group so that the group can continue to run? How do you code we have forums, management forums in RBMA. One of them is just on coding. Our doctors want to code it this way. We think it should be coded that way. And everybody shares about the best way to code an interventional radiology procedure or something like that. So it's really a critical part. And our motto that was developed was called progress through sharing. And still today, the networking, the sharing that these professionals do is really critical to, developing very good management and group practice. So it's a real simple formula, but it's gotten much more complicated.
Do you miss the days of paper billing?
No.
you change the complexity for the progress that
it's interesting.
Technology side.
Yeah, we used to have a state radiology practice managers group here in Pennsylvania. Every quarter we'd meet. There'd be 20 of us, 30 of us, and There was a woman, I forget her name. She would be there from Blue Cross Blue Shield of Pennsylvania. She was a physician relations person, and she'd review issues that they were finding. And then the person that managed physician payments for the Medicare intermediary here in Pennsylvania would come. It was really a great forum. But she said one time, we get, Blue Shield of Pennsylvania gets 82,000 pieces of mail a day. Okay. So, when you bill, you better make sure it's right, because there's 82,000 pieces of mail a day that come through our operation here. That was paper.
Yeah.
And we would get, when you get a check from an insurance company or Medicare, there's a payment advice that goes along with it. There's a paper that says, this check for $100 is for this patient for these 2 x-rays. Okay. And then a payment poster applies that into the system. Well, back in the paper days, the Medicare payment advice was, a box full of paper. And we would have staff, the payment posters would go through that line by line. And of course, now it's all electronic and you don't see the paper check. So the advancement of revenue cycle of billing software has just been phenomenal in terms of being able to bill and collect and manage revenue cycle and shorten those average collection days, et cetera, for everybody. Keeps the money flowing.
So the technology has improved, but the reimbursement levels haven't. The
Right.
past 15 years have seen a pretty consistent decrease in physician payments from Medicare. What are the key factors contributing to this downward trend? Take ourselves out of, the radiologist point of view for a second, put your government hat on. Why are they thinking this is a path forward? And then we can maybe put our radiologist hat on.
So I'm not going to quote the year of the legislation, but 15 years ago, I'm trying to think, it might have been, well, I'll be wrong if I quote it. Even when I was a Senate, I never kept track of bill numbers. So I still don't today. But several years ago, Congress basically established a path forward financially for Medicare and for hospital billing. The Medicare physician fee schedule is basically a pie that doesn't grow. Okay. So when Congress established the process around the Medicare physician fee schedule, there's no inflationary factor. So in order to keep everybody in that pie pan, they adjust in between different specialty groups, but the pie doesn't grow bigger unless at year end, Congress in their wisdom decides to throw some more money into the pie, which maybe makes the cuts smaller. When they established the hospital billing system, which is called HOPS, the hospitals get an inflationary adjustment every year. So their pie grows every year. The doctors' pies do not grow every year. And that is the basic flaw in the system, and one that, physician organizations have been working on. A lot of conversation around that in the past year to include a Medicare economic index, established it so that there would be an inflationary factor built into the physician fee schedule. A lot of reasons why it didn't happen. Probably part of it is going back to as simple as when it was established, nobody thought about it. And, if you're not there at the beginning, it's not going to be there in 10 years either. That, in a nutshell, is what happened.
Do you, as an advocate for radiology, in that experience, do you feel like you're in a zero-sum game against the other specialties? And so you're trying to say radiology is important, but primary care isn't. So you should pay us more and pay them less. How does that conversation work?
Well, it's a careful conversation because there has to be a balance. In my experience managing a radiology group, I could tell you in Lancaster, Pennsylvania, those radiologists are very close to the primary care physicians. They've supported them, they've taught them, and they have a mutual respect for one another. Now when it comes down to battling over the pie, that's a little bit different. But you have to have some empathy for the position primary care physicians are in. And part of the issue is the Medicare physician fee schedule is based around kind of procedurally based medicine. So, radiologists dictate one procedure after another, one report after another. And primary care physicians don't do many procedures. They might cut something off of somebody's face or do an injection here or there, but mainly a patient comes in with a cough and they see them and they manage them. And, the RVU factors aren't that big for that. So there's inconsistencies in that fee schedule, and those have to be corrected as well. And a lot of the efforts over the last several years, I think value-based care, MACRA, putting incentives on doctors that are face-to-face with patients, kind of helps the situation. There was also an attempt through the Medicare physician fee schedules. There was some revaluing of codes a few years ago to put more money to primary care physicians and others. Of course, it takes it away from subspecialists because the pie
Yeah.
doesn't grow. So those have all been efforts over the last 5, 6, 7 years to try to rebalance that. I don't know if it ever gets rebalanced.
So what are the groups that you're meeting with at your conferences doing to handle the reimbursement compression? You bring up MIPS and MACRA. Maybe some of them are trying to get some of those value-based care payments. I don't know if you're seeing a lot of that being adopted. Maybe you can share a little bit about that, or I know
Well,
you're
sure.
also passionate about potentially other models that groups could be thinking about.
Yeah.
What are you seeing?
Well, so MACRA was passed. Again, I'm not going to say the year because I won't remember it. I'll get it wrong. I think it was 2014. But basically, as a way to provide an opportunity for physician groups to earn a little bit extra, develop performance measures. One of the things that we have found out since then is that MACRA and MIPS, you could argue that it doesn't really fit into radiology real well. A lot of the measures are based on things physicians that are patient facing do. So, I mean, yeah, there are MIPS measures that radiologists can meet, but not as much as some other physicians, surgeons, and others have opportunities. So that hasn't worked out real well for radiology. Our board just in April at our annual meeting approved a motion to develop a radiology alternative payment model. So something that we have recognized that Congress and the committees in Congress that manage healthcare are looking for ways to solve this issue in the fee schedule or outside of the fee schedule. So we're looking at the development of a voluntary program that radiology groups could participate in, where perhaps you would establish a benchmark in a group in terms of performance, and then the group would be judged against that benchmark and have an opportunity to maybe share in some savings or get additional payments if they meet or exceed those benchmarks. So it's something that is in its real infancy with RBMA. We've just established a subcommittee to look into this. We have a couple of consultants we're working on. We're working with the ACR. They're very supportive of this effort as a group of business professionals come together and say, hey, we need to help solve this as well. We need to have at least something on the table. It may not be the end product, but Congress is looking for answers. The physician caucus in Congress, the doctors caucus last year in the fall under Doctors Barra and Bouchon, they issued a request for information on, are there ways for us to resolve this issue on the physician fee schedule? RBMA responded, as did several other groups. So that's going to be interesting conversation as we go through the year here and into next year.
Really interesting. You say productivity benchmarks. Do you have any early ideas of how that might work, or what you guys might be looking for in terms of, ways to drive savings?
Well, yeah, some of the things we would look at or suggest would be measures like, appropriate measures. Are we working with referring physicians, like through clinical decision support and appropriate use criteria? We have developed systems, they just are not utilized totally now,
Yeah.
but how do we use those? Are those helping drive a group to meet a certain benchmark? Obviously, developing outcomes measures are very, very important. Care coordination with other subspecialists are very, very critical in terms of radiology cost and trying to reduce costs. Maybe even things like health equity measures. How are we developing health equity within the system for groups of people that can't get radiology or that are missing their mammography screening and those types of things. So just looking at a whole group of quality measures that perhaps are more focused than some of the MIPS measures are now, and
Yep.
that radiologists can actually participate in and meet and develop benchmarks or develop some value and rewards going forward.
Well, and I think it's critically important, and from my discussions with private practice leaders over the past they all say, yeah, we looked at MIPS and MACRA. It turns out we can't quite meet all the measures, or the cost to try and meet it, kind of vastly outweigh
Right.
the benefits. So finding ways for radiology to have a seat at the table is important. I think bringing the coordination together is also a key piece of it. So I think partnering with the
Right.
ACR and other practice leaders, both, I think you guys do a good job representing a lot of small, mid-sized private practices. How do you also bring in large conglomerate style practices and everyone in between, and find something that works for people?
Yeah, most of the MIPS measures, they were supposed to provide this kind of increased payment to high performers. But what we found out, and what Congress has found out, is that there's this huge middle tier of physician groups that just can't kind of play in the game
Yeah.
for whatever reason. That doesn't mean every practice should get big enough so that they can play in the game, because there's models all over the country, especially in rural areas where practices aren't that big. So it's a balance, and we're trying to, find that balance, find that right sweet spot. Yeah.
Well, and I imagine your experience working in the state Senate kind of uniquely prepares you for such efforts. What was that
Yeah.
experience like? What have you learned that could maybe help others who are passionate about this area? I read a lot of Twitter, a lot of
Oh, you do?
radiology Twitter, okay? And I'll tell you,
Thankfully, I didn't serve when there was social media and
yeah,
Twitter.
yeah.
So,
And I think there's a lot of people on radiology Twitter
mm,
that will
mhm.
voice their discontent about things.
Yeah.
How do you pull all that together in a way that's then impactful? As you mentioned, like at the start of the show, where you found the right senator who could, affect the change.
Well, government isn't like the West Wing. Not every problem gets solved in 45 minutes. Regrettably, most people think it does. One of the things I learned, I thought it was interesting when I was new in the Senate, was that so much of state legislation, or the bills we worked on, had to do with things that happened at the federal level, that then the states all had to adjust their laws to meet. So we would pass a lot of legislation that was just nobody paid any attention to, but we had to tweak things because the federal government, the Department of Transportation did this, so therefore we had to do that. There's a lot of that happens in state government, a lot. And also
Yeah.
in local government, you got to pass some ordinance because, the state passed a law, the federal. So that's kind of interesting in terms of the machinations of government. But for me, I mean, it was, for me, obviously a real keystone of my life, serving in the state Senate at that level. I was fortunate enough to get appointed to the Capital Spending Committee, the Bond Bill Committee in Delaware, and then the Joint Finance Committee that wrote the budget. So I spent a couple of years on each one of those committees. So that was really helpful and interesting on how the state balances their budget on the revenue and spending sides, how those are negotiated in a room with 12 people, and, who needs what, and we can get a little more revenue here. A nickel a can on beer generates a lot of revenue. And every once in a while, you just got to tax beer a nickel a can. I know that wouldn't be helping in Utah, where you are. Pennsylvania does not have a beer tax, which is amazing to me.
Wow.
But that's just one.
As someone who's lived in Pennsylvania, that's a lot of lost revenue. There's
That's
a
a
lot
lot
of
of
beer
lost
being
revenue.
drank during those
Yeah,
Eagles
so
games.
I'm a big fan of, nickel a can. Anheuser-Busch, not so much. So, one of the things that I appreciate, because I've served on it, is that, everybody has kind of their own interest and their own folks they represent. And at some point, you have to kind of put those aside and govern. And governing's a really hard thing. We see it now so much because of social media and the 24/7 news cycle. I mean, I don't know how those folks can govern, because I think it's very, very difficult to get into that room and sit down and have that conversation. On the federal level, the recent debt ceiling deal, at some point, the president and his people had to have that conversation with the speaker and his people. And then the ball started rolling, and you hear about all these side stories about this person likes that person, or they had a connection, or, and it kind of got things going. Guess what? That's how it's always happened, you know?
Yep.
And, you can read back in our history, and, the big deal of where will the capital be? Well, it ended up being down Virginia, because the guys in Virginia were powerful and wanted it there, but they had to agree to Hamilton's idea for refinancing the government, that kind of thing. So they got into a room and they figured it out. And it's still the best way for our government and for democracy to do things. And so I'm a big believer in that. And as now a person that does advocacy for physician groups, at some point you have that right conversation with a member of Congress about an issue, let's say mammography. You'd mentioned that. There's a bill in Congress called the Find It Early Act, which would forbid any patient copay or deductible for advanced women's imaging. So, a woman comes in and gets a mammography screening, they find an issue, you got to go back for a diagnostic mammography. About 40% of the women that have an issue don't go back for that advanced breast imaging, the diagnostic mammo, because there's a potential copay of up to $1,200 on the average.
Wow.
So they don't get it done. So, you know what happens? It gets worse maybe, or, gets worse now the bill goes up because there's a cancer there. So, they really are health equity issues.
Yeah. And if someone wanted to get involved in that, how would they get involved?
Well, RBMA has a federal affairs committee, which is really important. They're the group that kind of reviews all of our stances on legislation. They help develop the comment letter for the Medicare physician fee schedule every year. A really knowledgeable group of volunteers. And also our Radiology Patient Action Network, we have developed a website called don'tcutdocs.com that we activate. It'll be going here at year end because we're going to be faced with cuts again this year. And we ask our members just to go on that and respond. That message is sent to your member of Congress through the magic of artificial intelligence. We know where everybody lives. So those are really, really important. We had 7,000 messages sent to members of Congress last year from our members and their physicians. And we think that has an influence. We think that's really important, like all groups do. But we feel very proud of the fact that we've been able to generate that type of grassroots support over the last several years. We work closely with a coalition of radiology organizations, including the American College of Radiology. We have monthly calls with them about issues and how do we manage those issues. They are very skilled and adept and know what I call the inside the beltway game. And we think we're very skilled and adept at developing a grassroots network that can support their fine work on Capitol Hill. So we think we have a role in that, and that's very important. And the other thing is that our radiology professionals, our business professionals, play a really key role in terms of providing data that then the college can use in their advocacy. So we all have roles to play, and we try to play those roles very well.
So we've talked a lot about how billing has changed since you've been in the industry. A lot has changed on the practice of radiology, of course, as well. As you kind of look forward, do you look forward with excitement about the field of radiology?
Yeah, I mean, there's so many interesting things. Artificial intelligence, you could do 2 or 3 podcasts on that, and I'm sure you have. And I know Modality Works, part of your product is based on that. That's just a really exciting area. I have found just the clinical technology to be so fascinating in my history. I mean, I started in radiology in 92. So to put that into perspective, in 1981, our oldest son was born, and that was the very early days of ultrasound. So, now your wife gets pregnant and she gets, I don't know how many ultrasounds, your wife got a bunch of ultrasounds, right?
Oh, yeah. Oh, yeah.
Not so much 3 back then.
I've got 3, not 7 yet, but
not you're working on. The next 4 are no big deal. But, I saw the advancement of cross-sectional imaging, CT, MRI, they're bringing in a PET scanning, and then that now is more advanced with PET CT scanning. But as I was saying, the advancement of the clinical imaging is fascinating, and it says a lot about radiology's role in diagnosing something in the human body at a very early stage so that then, another specialty, they could be treated or fixed or, that goes a long way to saying people are going to live longer. If we can find it earlier, people will live longer. And that's fantastic. Yeah. So I'm excited about that. I mean, the use of artificial intelligence in billing and revenue cycle management is fascinating to me. And we all like it. You get the bill on your phone. You can pay the bill with your phone. Don't have to get a letter in the mail. That's kind of interesting from one that, came from paper.
Well, and it's such a great point because at the end of the day, technology will follow behind where the capital is. And
Yeah.
there's a lot of data in billing. There's a lot of problems in revenue cycle management. And so,
Yeah.
we're gonna talk about getting a general intelligence for diagnosing scans, and what we're gonna get is better, faster, easier billing.
Right.
But it turns out we're pretty bad at billing, and we're pretty
Yeah.
good at diagnosing things as humans. So
It's really interesting. You talk about telling a story to folks in public policy, whether it's staff or elected leaders. I think it's important to tell the physician and the patient billing story because it's complicated. It's hard to explain to people why a patient who is insured has a copay or a deductible. Let's face it, most folks that are working that have insurance pay no attention to their insurance until they need to use it, and then are shocked that there's I had $1,000 copay. I didn't know that. Well, that's shame on the doctors for billing that. I'm like, well, it's your insurance company. You have you bought the insurance. It's $1,000 copay. So I think because health insurance is complicated, and because generally people don't have to use it until they have to use it, they don't understand it. And so explaining that to public policy people is very, very important. And we do a lot of that. I'll tell you a story. There was an issue around ultrasound payments through Medicare that were getting ready to drop. And we were working on the issue, and we had a meeting in the Office of Management Budget in DC, and, our folks were there. There were about 6 people in the room, and the young Office of Management Budget staffers were there. There was a woman that was kind of the leader of their team that was a little more mature. And we're talking about ultrasound. And I kind of paused. I said, how many of you have ever had an ultrasound? Well, only the woman had, she was old enough to have kids. Nobody else had. I said, in fact, you probably haven't been to the doctor in the last 5 years. Well, that's right. We're 31. We're healthy. I said, well, this is what an ultrasound is. And you really have to start at that level with a lot of folks handling public policy because they haven't had that experience. And it's really important that you do that. They don't understand it. So that's what we try to do, is explain it that way. Or that's what I try to do.
That's really smart. You get a bunch of 25-year-old staffers making medical decisions for 70-year-olds on Medicare.
It's look around Congress, huh? On the nightly news when they're interviewing, Senator so-and-so, look at the people standing behind them. They're not, they're pretty young, smart young people.
Well, last question for you, what advice do you have for the young business leaders, young radiologists, maybe they're wanting to build a practice, rise up in their practice.
Sure.
What advice would you have for them as they embark on their careers?
Well, for the young radiologist, I think it's important that they appreciate, number one, they have a license to practice medicine that is invaluable. It's worth more than they think it is. And no matter what kind of practice you go into, it's about the practice of medicine. If you do that well, everything else will follow. And it's a long career. You can't figure it out on day one, but you're going to make very good money compared to most people. You're going to live a very nice life. Don't sweat, this year I made X, but next year I made X minus Y, but next year I might make X plus Y. It's a long career, and you got to look at it that way. It's a marathon. And, challenge yourself. The doctors that I worked for challenged themselves clinically. They brought on all these new modalities. They would get excited about studies. And I would encourage our young physicians to continue that. Get excited about the work you do, because it's really fascinating work and you're saving people's lives. That's really what it comes down to. For the business professionals, this is a wonderful career. You work with smart people. It's challenging on the financial side to make sure that the 15, 20, 100, 3,000 doctors you work with are getting paid every month. But it's a fascinating, challenging career because you're working with science and technology, and you're also working with the patients who need your focus and need you to do that right so they can get to the next paycheck, that type of thing. So I would encourage folks that are thinking about a career in management that physician practice management is a great career to have. So I'm very bullish on that for folks that are, getting an MBA or coming out with a management degree or a business degree. There's a real opportunity here. Again, we're going to need good people in this field.
Well said. Well, Bob, thank you so much for coming on the podcast.
Thanks for having me, Daniel.
Thanks for listening to this episode of the Radiology Report podcast. Be sure to visit us at theradiologyreportpodcast.com or subscribe to the show wherever you get your podcasts to join us for our next episode. We are always looking for great guests. If you have someone you'd like to hear on the show, please get in touch with us online.